Thank you. Good afternoon, everybody. The audio for this presentation automatically streams through your computer. For the best viewing experience, make sure your computer is connected to reliable internet and that the speakers are turned up. If the computer audio option is not working for you, phone lines are also available. You can access the telephone number by clicking on the black phone icon that's at the bottom of your screen. Today's session will include presentations and moderated discussions with 3 subject matter experts in IDD. The session is being recorded and will be posted along with the recording and slides on resourcesforIntegratedCare.com. You can also download a PDF of today's slides on the resource pod located on the left side of your screen. We are pleased to inform you that continuing education credits are available at no additional cost to participants. The webinar is approved for 1 continuing education contact hour by the National Association of Social Workers and for 1 continuing nursing education contact hour by the California Board of Registered Nursing. We strongly encourage you to check with your specific regulatory board or other agencies to confirm that courses taken from these accrediting bodies will be accepted by that entity. This slide displays the continuing education credit options based on your role as either a social worker or a nurse. In order to obtain credit, participants must complete the pre-test at the beginning of the webinar, followed by the post-test no later than August 10th at 11:59 p.m. with a score of 80% or higher. This webinar is supported through the Medicare-Medicaid Coordination Office at the Centers for Medicare and Medicaid Services. MMCO is helping beneficiaries duly eligible for Medicare and Medicaid have access to seamless, high-quality health care that includes the full range of covered services in those programs. To learn more about current efforts and resources, please visit our website, resourcesforIntegratedCare.com, or you can follow us on Twitter or LinkedIn for more details. Today's session will include 3 20-minute presentations on strategies for delivering person-centered care for individuals with IDD. Each presentation will be followed by a brief question and answer portion. So at any point during today's webinar, you can submit questions to the presenters via the Q&A pod located on the left side of your screen, and we will answer as many questions as time allows. At this time, I'm very pleased to introduce our wonderful panel of speakers. We are delighted to have Dr. Emily Lauer, who is the Director of the Center for Developmental Disabilities Evaluation and Research at the Eunice Kennedy Shriver Center, as well as an Assistant Professor in the Department of Family Medicine and Community Health at the UMass Chan Medical School. Dr. Lauer's work focuses on applied research, evaluation, and policy efforts to improve the health and well-being of people with IDD and other vulnerable populations. She conducts health surveillance and systemic quality improvement for these populations at the state, national, and international levels. Our next speaker will be Dr. Joan Beasley. Dr. Beasley is a research professor and director of the National Research Consortium in IDD and Mental Health at the National Center for START Services at the University of New Hampshire. Dr. Beasley is a licensed mental health counselor and is the author and co-founder of the START model, which we will learn more about today, a service linkage crisis prevention and intervention program to improve capacity for effective services and supports for children and adults with IDD and mental health needs. And finally, our webinar will conclude with the presentation by Dr. Stephen Deutsch, who serves as the Chief Medical Officer for Partners Health Plan of New York. Dr. Deutsch is a board-certified orthopedic surgeon trained at Columbia and Harvard, where he served as chief resident at the Massachusetts General Hospital and on the faculty of Harvard University. I know that you're all going to enjoy hearing from this incredible lineup of speakers. So Dr. Lauer, Dr. Beasley, and Dr. Deutsch, thank you so much for being with us today. As I mentioned, my name is Melanie Norris, and I am with the Lewin Group, and I will be moderating today's event. I am also joined by my colleague, John Jansa, who will be facilitating the Q&A portion following each presentation. This slide describes our learning objectives for today's session. By the end of today's webinar, participants should be able to describe the current gaps in care for individuals with IDD, provide strategies for delivering person-centered care for individuals with IDD through the use of innovative care coordination models, and understand the impact of these strategies on outcomes of care. Now, before I pass it over to our first speaker, we would like to launch 2 quick polls to get a sense of who is in the audience today. As you should see on your screen, our first poll is, which of the following best describes your professional area? Are you part of a health plan as a case manager, customer service representative, or administration and management? Or are you part of the medical field through nursing, physician assistant, pharmacy, social work, or advocacy? Please take a minute to respond to the poll, and we will push the results out in about 10 seconds. I see we have about 45% of attendees who have responded so far. So I'm going to give it about 5 more seconds and then show the results. Okay, it looks like most of the people on the webinar today are health plan case managers or care coordinators, and we have some representatives from management and administration, as well as medicine, nursing, and social work. Okay, next I'm going to ask, in which care setting do you work? Are you working in a health plan? Do you work for an ambulatory care setting, long-term care facility, home care agency, community-based organization, consumer organization, academic research organization, or other? We'll give it about 10 seconds for people to respond. So far, we have about 40% of the votes in, so I'll give it another 5 minutes, or sorry, 5 seconds. Okay. Not surprised, it looks like most of our audience is from a health plan. We also have some representatives from community-based organizations and some long-term care facilities. Thank you, everyone, for providing that feedback. I think based off of these results, I'm sure that the folks on the call today will have a lot to learn from our speakers. So without further ado, I am pleased to turn things over to our first speaker, Dr. Emily Lauer, to provide an overview of health outcomes and the current state of care for people with IDD. Dr. Lauer, please take it away.
Thank you, Melanie. Next slide, please. So I'll talk today about what we know about health challenges for people with intellectual and developmental disabilities, as well as the current state of health care for them, and some particular clinical-related conditions and challenges that they experience. So we know worldwide that people with these disabilities experience a wide array of different health inequalities and, unfortunately, violations to some of their basic human rights. So if we compare people with intellectual and developmental disabilities to people without these disabilities, we know that they're more likely to live with complex health conditions, many of which are chronic. These chronic conditions often are more poorly managed than people without these disabilities and may include less common conditions like epilepsy. They also have more limited access to high-quality health care and health promotion programs that are uniquely targeted to the needs of these individuals. We see that they receive preventive screenings at lower rates, particularly cancer screenings. They're more likely to experience obesity. And many different projects who have conducted community-based evaluations have found undetected vision, hearing, and dental problems. And people with IDD are more likely to have mental health problems, as well as be overly prescribed on psychotropic medications. And we'll talk a little bit more about why that is in a moment. Next slide, please. If we consider how people with IDD access care and their experiences, we know that they face a large array of barriers of access. So this includes providers who may not know or be comfortable with supporting their individualized needs, particularly related to things regarding their disability. There are a limited number of specialists who accept Medicaid and Medicare, and people with IDD have a greater need for specialists of different types and arrays, so it may be harder to find them in their communities. And they need to navigate what we know to be a complex system of care. And so if you consider some of the executive function challenges that present in people with intellectual and developmental disabilities, it makes it even harder for them to navigate these systems of care, which can be hard for any person trying to receive services. If we look at the history of inclusion of people with these disabilities in managed care, it really varies. Some early programs really struggled to adequately serve this population, in part because they tend to need a greater number of services and more frequent services. And they also need some really skilled case management, and I think early programs may not have had this particular skills. There are, however, pockets of excellence in what we see in the community-based care system, including some interdisciplinary clinics that have done a really nice job of training up their clinicians and supporting each other in approaching a person-centered care model for these individuals. And we know that there are gaps in quality measurement, and I mention this because newer models like value-based care really focus on outcome measures. And so where we don't have good relevant measures for this population to ensure their needs are included, particularly some of their more unique needs, they tend to not get emphasized. And so that is an additional gap. Next slide, please. So when we look at how and why people with IDD access health services, we see that they are more likely to use the emergency department in a given year, for example, and also to be hospitalized. When we look at why they're using the services, we see more what we would call suboptimal utilization, so needing to go to the emergency room for conditions that could be treated if recognized early in an ambulatory care clinic or outpatient services, and also some utilization that's preventable. We do see a big, what we would call a behavioral component to why people are visiting the emergency room, and this underscores a greater need for community-based mental health care and crisis response for these conditions that understand how to work with people with these disabilities, including people with autism. Unfortunately, the emergency department can become the provider of last resort in these situations. As I mentioned, people with IDD are less likely to receive health screenings. We've done some work to try to figure out why that is. And we see fewer referrals for screenings by clinicians. There's been some feedback from clinicians that they might not want to try to put someone through a preventive screening. But of course, if we think on the other side of the options when you detect a condition at a late stage, that often is an undesirable experience as well. So we're trying to work on education for clinicians and support to have a person-centered approach to considering screening options. We also see some hesitancy with people who are supporting people with IDD, so guardians and family members, may be hesitant to put someone up for a recommendation for a screening that may be uncomfortable or a little bit scary for them. We also see people who have special positioning needs, such as women who may not be able to access traditional mammography, experience challenges in getting the screenings they need. And we have seen some programs with some success that do what we call desensitization. So we think about a new screening experience and the equipment that's used and the whole experience to walk someone through that ahead of time to allow them to touch the equipment, get more comfortable in the environment and understand what will happen during the course of the screening can really help reduce anxiety during that process. The advances in screening also give us some opportunity to create more individualized recommendations. So there are newer screening options. If we think about colorectal screening, for example, we now have more fecal occult blood testing options, which is stool sample instead of needing to go through an invasive procedure. So while not every one of these new screening options will be appropriate for every patient, there are some greater options, and that might include ultrasound for breast imaging instead of mammography. So for some patients who may not have been screened at all in the past, these newer options may be a good frontline approach to see if further care is needed. We also want to work with beneficiaries and their supporters to understand why the screenings are important, what will happen during the screenings, and how to make screening appointments that suit their needs. So they may need appointments with extra time or certain times of the day or at locations that are more accessible to them. Next slide, please. When we think about how to optimally support health for people with intellectual and developmental disabilities, we first want to listen to the beneficiary to understand their own strengths and needs. And if the beneficiary can't tell you that themselves, then ask the people that they choose to support them and are surrounding them. There are some really helpful models that have come out to emphasize some of the key components to making person-centered care accessible for this population. So we can't assume a high degree of health literacy really in any of our patient populations, but we want to make sure people understand the conditions that they're diagnosed with and how to optimally support themselves. There's a model called Communicate Care that came out of Surrey Place that has a nice broken down component of how to communicate and interact with patients. So they really emphasize getting to know your patient, including their accommodation needs, creating a safe and comfortable space to support that person, accommodating their needs and through things like we talked about with appointment times or physical locations, and to establish a rapport. And if you consider how to communicate here, you want to be really clear in your communication, to be listening attentively, to be really responsive to their concerns, and engaged with the patient. And if you think about the different components here, these work for many different types of beneficiaries and patients, not just people with intellectual and developmental disabilities. I also want to make a note here about behavior. Behavior in people with intellectual and developmental disabilities is often really misunderstood. It is communication, and it should start there. And when we train our medical students, for example, we use a HELP model, which is an acronym that really breaks down how to consider behavior first as communication and very last as either a psychiatric condition or just an undesirable behavior. Often people with intellectual and developmental disabilities may act a little bit differently when they have a medical condition, when they're in pain, when they're experiencing some symptoms in a way that you or I might vocalize. We also want to consider environment. So is there something stressful happening around the person or something agonizing? Thinking about lived experience, there's a much greater history of trauma in this population, including abuse and neglect. So sometimes behavior is related to past trauma. And if it's no to all three of these things, it's kind of only then that we pursue the idea that their behavior, especially if undesirable or adverse, might be a psychiatric disorder. The opposite of this order is what has happened, unfortunately, historically. And so there are teams that are doing a better job of really working through this, but it's an important consideration. As we'll talk about in just a moment, too, there are a number of specific risks and conditions that people with IDD are more likely to experience. So we want to be sure to assess their various risks, including the risk of trauma, and to mitigate those throughout their relationship. Promoting advocacy is also really helpful because, as you can see with the barriers that are experienced, advocating for each person's needs is a key part of ensuring that they receive high-quality health care. Next slide, please. So in managing chronic conditions, we want to be thinking about how to make that person, that beneficiary, and their supporters as skilled as possible in supporting themselves. And often that means educating that person and the circle of support around them. So if we think about trying to make lifestyle modifications like dietary changes and other things, it's a lot easier if people do this together and they're all on the same page as opposed to one person in a household, for example, trying to make a change while everyone else there around does not. So we want to include and engage the circle of support. And people with IDD may need some additional assistance to help make these lifestyle changes like diet and exercise to make sure that they are managing their chronic condition and that they know when to seek help if there's a sign or a symptom that emerges from that condition. There are, unfortunately, a limited number of chronic condition management programs that really apply to people with IDD. So there's evidence, for example, that some of the individual diabetes management programs, for example, don't always do well extrapolated for this population. So there is a greater need for more patient-centric approaches. We also know that from what we've assessed through claims data that physicians are not as likely to adhere to all of the quality components of clinical management for chronic diseases for people with IDD as they are for other people that they're treating. So the diabetes is also a great example here. If you know the NCQA components of comprehensive diabetes care, for example, they're much less likely to receive all of the different components that make high-quality care. So it's a place for education and for advocacy. Next slide, please. As I mentioned, there are some conditions that people with IDD are more likely to have, and these include what we call the fatal five. These are bowel obstructions, infections of various kinds, but predominantly urinary tract infections, pneumonia, and cellulitis, aspiration, dehydration, and seizures. And there are a whole number of reasons why people with IDD are at higher risk for these conditions, but it includes some of their comorbidities, the medications they're taking, particularly psychotropic medications, and the side effects, some of the lifestyle factors, and their need for support from other people. We want to make sure in preventing these that we take a couple key steps. So as I mentioned, first, we want to assess risk and to mitigate that risk. We also want to take some preventive approaches. So ensuring hydration, good diet, bowel health, making sure we're not over-prescribing sedating medications or those that contribute to constipation, and making sure we're taking infection prevention approaches can all help mitigate what we would call the fatal five. It's also really essential to act on early signs and symptoms and to recognize these. As we talked about, they may not always look like they would for other people, or they may be have unique ways in which a person with intellectual or developmental disabilities expresses pain or discomfort that we want to recognize and pay attention to. Next slide, please. The polypharmacy is a really big deal in this population. People with IDD, especially adults, tend to be on a staggeringly high number of medications at the same time, and we particularly see polypharmacy in psychotropic use. So some of the reasons for these are mistaking behaviors for mental health conditions, and so there's overuse of things like antipsychotics in this population. We also see more meds being added the more someone goes to the hospital or the ER trying to treat what's emerging at the time, but very often those meds aren't walked back if they're not needed. We also understand that sometimes people with varying conditions look like they have other conditions when they show up, and that's where provider education and support is really critical to be able to help them distinguish what's actually going on. And we see also that some of the medications that are frequently used have side effects that are then managed with additional medications. So you can see where we enter into a cycle of more and more medications as a person gets older. There are multiple downstream effects of that polypharmacy. It does include, unfortunately, increased morbidity and mortality, but it points right back to the fatal five as well. So more constipation, more bowel obstructions, more dehydration, and things of that nature. Next slide, please. So in terms of improving access and quality here, we want to think about hitting a number of different barriers. So we want to ensure a good provider capacity of specialists, not just IDD specialists, but specialists who accept Medicaid, Medicare for all the populations. We can overcome provider reluctance by providing education and support. There are some innovative models looking at things like an ECHO model, where there are clinicians who have experience with IDD who can be a source of advice and referral for other clinicians like primary care physicians who may be working out in the community that can aid the ability to treat this population. So really thinking deeply about how we scale up and build confidence in our providers about how to care for this population. We also want to provide skilled care management here, really understanding the needs of people with IDD and making sure that they can navigate that complex system. And that may really involve a start to finish kind of approach where you're making sure that they're able to successfully not just get that appointment, but get in the door and receive the services there. We also understand that, as we talked about with the diabetes care example, access is not necessarily sufficient to achieve quality. So we want to make sure that our physicians are really supported to apply the evidence-based practices for this population, really be thinking through those steps and ensure that they get all the different components they would think about for other populations as well. Okay. That's it. Thank you very much.
Great. Thank you very much, Dr. Lauer. We have now entered the Q&A portion for Dr. Lauer's presentation, and I want to first thank those that submitted questions during Dr. Lauer's presentation. We will do our best to ask and get answers to the questions that are raised, and including for those questions that were submitted during registration, which we appreciate everyone's input. Dr. Lauer, we did have some questions come in during registration, and so I'd like to begin. You talked a little bit at the end of your presentation about ways to improve provider capacity. One question that came through was, what do you recommend health plans prioritize if they would like to improve provider capacity for providing healthcare services for people with IDD?
I would say two things. First is education. I think using the continuing medical education credits is a helpful way. We have to keep in mind that many medical school curriculums did not include content on how to treat people with intellectual and developmental disabilities. That is changing, but it's slow and it's not universal. So we can't assume that they've had a chance to really understand the unique needs or how to communicate with these patients. And, sometimes it's intimidating and we want to build that confidence. So the education would be the first part, and then support would be the other. So if you're going to launch a program, for example, where you're enrolling a number of beneficiaries with IDD, you want to make sure there's skilled support as a resource. So if these providers have questions or they're feeling stuck or they're not sure what to do, that they have a skilled resource, another clinician they can reach out to coach them, to guide them, provide them some advice.
Great, thank you for that. A question tied to that then, for many people in the community that are serving people with IDD, as people with IDD age through systems, one of the questions that came through during registration was how to best support individuals with IDD as they age out of a pediatric system into more of an adult system, and how can families and caregivers and health plans support individuals with IDD as they age through these systems?
Yeah, I think that's a great question, in part because there's substantial differences in the models of care currently between the pediatric and the adult system. So we really want to be thinking about that transition early. Some of the stronger systems start having these conversations about what that person will need in their adult life as early as 14 or 15, so that there's multiple years to have that conversation and to be understanding, for example, how much support will that young adult need in making decisions, understanding that once they become an adult, There may be an opportunity for models like supported decision-making, sometimes guardianship, but we want to, support somebody to be as independent as possible. And so thinking about the right model to help them advocate for themselves, and then also making sure that there's a warm handoff with the adult provider. It can be challenging to find adult providers that will take young adults, so that will take some time sometimes. And we want to make sure that those clinicians have an opportunity to work with each other, talk with each other, so that there's a continuum of care and it doesn't feel like a hard switch from one system to the other. So those would be some of the tips I have, depending on whether you're a family member or even a care coordinator or a provider, encouraging those conversations to start early is very beneficial.
Great, and we had some great questions come in on the Q&A, so I'd like to raise one of those up. Dr. Lauer, reflecting on the claims-based analysis that you noted in your presentation, are there any specific programs or initiatives that you can cite that are aimed at improving the quality of care?
Well, I think there are a few out there. The analysis we did involved multiple states across the U.S. and just came out fairly recently. So I think we're still working on the next steps of trying to work with local public health programs and others to build materials that are specifically designed for chronic condition management advocacy, in encouraging people to inquire with their clinicians and advocate for the support they need. And then I think there is an opportunity to do more education and outreach related to these conditions to ensure that people with IDD are able to take advantage of what we already know constitute, quality care, because diabetes care clinically for someone with IDD doesn't necessarily look any differently than it does if you don't have IDD. The patient support may, but the tests you need to run and things may be very similar. So we want to make sure that we're not seeing inequalities in those components. And I think where we have an opportunity to pay for and monitor those things, healthcare plans have a good role in this. They can be an influencer to make sure that clinicians are providing the high quality care to this population as well.
Thank you so much. A follow-up question, again, talking about some of the contracting initiatives around value-based care. Can you speak to a little bit, how do you propose value-based systems can best serve adults with IDD when considering from a contracting perspective and considering adults with IDD as they age into the senior or elderly realm?
Yeah, I think sometimes the targets that are chosen for a larger, more diverse value-based care program don't always consider the specific needs of people with IDD. So I do think there's more work to be done to figure out what the right targets are. We've been engaged in some early work in that, but thinking about what does this population really need, what does success look like, and ensuring that you have the ability to measure it for this population. Sometimes they get a little bit lost in the larger population emphasis, but they are high utilizers. They have, as we talked about, complex care needs. So when you're looking at the value-based outcomes, both in the design phase but the measurement phase, I think being able to carve out this population for specifically understanding do they get the value-based outcomes too is beneficial to see how your program is functioning.
Great. And we may have time for one or two more questions. One question that came in through the Q&A. Very often there's discussion about how providers can take additional steps to serve adults with IDD, individuals with IDD. How can providers best be supported to offer the time and expertise they need to effectively provide health care for individuals with IDD?
That's a great question, and I do think the providers need to have the resources, financial and otherwise, to be able to carve out the time to really thoughtfully provide care for this population. I think we often see that longer visit times are needed, But in addition to visits, a longer amount of time to be able to connect with other clinicians that are supporting that individual, to really work with a team-based approach to provide care, because that's where we see more optimal outcomes for this population. And so where there is a managed care environment, I think that presents a lot of opportunities to ensure that the providers have the space and time that they need, as well as the skilled support to be able to serve these individuals really well.
Great, thank you so much. And again, thank you everyone. We will take Q&A sessions after each presentation, so as a presenter is providing their content, please feel free to add your questions and we'll do our best to ask as many as we can get to. At this point, I want to take us now to our next presenter, Dr. Joan Beasley, who will be presenting on the START model. Dr. Beasley.
Hi, good afternoon. First of all, I want to just say what an excellent presentation Dr. Lauer just had, and a lot of what we're going to be talking about will have relevance based on what she just presented. So it's a very nice segue. Next slide. So as Dr. Lauer described, my focus is on mental health needs in people with IDD, and many people with IDD experience numerous health disparities, including higher rates of mental health symptoms and behavioral challenges compared to their typically developing peers. And I think what I would say to sort of add to what has already been described is that there is a social construct to this that can't be ignored, that people suffer from trauma and disparities associated with having IDD almost from birth. People are underestimated. They're kind of robbed from their optimism once they're diagnosed, and this really contributes to especially mental health issues in the population, and a high percentage of people have suffer from trauma. People are often misdiagnosed, underdiagnosed, or undiagnosed, and even when it's detected, few evidence-based treatments exist in mental health. This gap has translated into the very costly and ineffective care, and as described just a few minutes ago, results in frequent emergency department and psychiatric hospital visits for people with IDD, and poor quality of life and earlier age of mortality. Again, as described earlier, the way I describe the population is I refer to them as having IDD-MH, not dual diagnosed or comorbid, but IDD-MH, which is to say that the population has mental health service experiences. Whether or not they actually have a mental health condition is sort of ranges from they certainly do to they absolutely don't, but they receive these treatments anyway. And there's little research on best practices for individuals with IDD-MH, and the population is often misunderstood, underserved, and underestimated. Next slide. So START was developed in 1988. It stands for Systemic Therapeutic Assessment, Resources, and Treatment. The term systemic applies to the therapeutic assessment and resources as well as treatment modalities incorporated into START. We believe that things have to be linked, that there's a social context to it, that collaboration is key. Certainly, managed care is one of the avenues to get there if people are well-trained and understand the population well. We first developed START in 1988. I am the author of the model. My colleague, Dr. Robert Sovner, who was a psychiatrist, worked with me on the model back in the late 80s, and it was first cited by Dr. David Satcher, the Surgeon General, in 2002 as a model to help overcome disparities in access to mental health care. Many of the people served through START are dual-eligible individuals, and our national center trains local community providers in the START model. We also have mechanisms for physicians, clinicians, people with lived experiences, and others to collaborate across the country to enhance their capacity and share knowledge. We have practice groups in all kinds of areas as a result of the network that's been built. START teams provide cross-systems crisis prevention and intervention planning, networking partnerships, as I just described, mental health assessment and coaching, and 24-hour crisis response, outreach, and training. There are START programs located currently in 12 states, and we have 10 additional network partners that use START practices of one sort or another. In 2021, the START program served 4,000 people with IDD-MH across the lifespan in that year. We have approximately information for approximately 11,000 people in the START database currently that we use to evaluate how things are going. Next slide. So START is a public health tertiary care model that uses this approach to build capacity and reduce the use of emergency and crisis services for individuals with IDD-MH, and also to increase their service experiences and their mental health. In stage 1, we determine the level of acuity, we provide hands-on training, share information and advice amongst beneficiaries, families, and service providers, and ensure there's a coordinated continuum of care in place to respond to their needs and wishes. We also, in stage 2, identify triggers that lead to crises, conduct ongoing assessment, engage in robust cross-systems crisis prevention and intervention planning, and integrate health and wellness activities as part of the remedy. In stage 3, which is crisis management, there's proactive management of crises when they do occur through the use of after-hours crisis response, in-home emergency supports. Therapeutic coaching is one of those devices that we use, crisis stabilization beds, and ongoing training development of newly identified interventions. Next slide. So START focuses on community linkages. It's a systems linkage model and capacity building across the system of care rather than segregated, siloed, or duplicative services. It's key to build linkages across clinical teams, training and consultation providers, and therapeutic resources so that everyone works together and with other key stakeholders. And by bridging these linkages across the systems, we can break down those silos. And as a result of the linkages, both Medicare and Medicaid recipients can experience efficiencies and cost savings associated with that. Acute care utilization is reduced, and more cost-effective long-term support services can be identified. And this includes the reduction of the use of restrictive services. So while medication is certainly a big problem, polypharmacy, so is restricted, segregated services for this population. Next slide. So here is our framework that is research-based. We've been researching the model since 1988, and this is the most recent framework based on the analysis of data. There are 4 core components to the model: intake and assessment, consultation and mental health skills coaching for individuals and their caregivers in their primary settings, 24-hour urgent response and intervention, and linkages, including referrals, outreach, and training to the system of care. The research outcomes include increased capacity in the system of care, decreased use of crisis services, and increased satisfaction with services received, and increased mental health stability overall. The thing that I think is really important about this is the use of research and fidelity-based models allows for increased ability to be able to have remedies work sooner than just sort of kind of trying to work it out on your own as an independent service provider. So while it took the first iterations of the START model, it took about 3 years to gain stability for individual service users. It now takes about 8 months before we reach stability and we find increased service capacity and understanding of how to go forward. And this is very, very important. I need to mention, however, that we have not discussed the role of race and ethnicity and bias about the population. where you live matters. There are differences in access to care between urban and rural settings. Your severity of your intellectual disability matters. Your health, primary health conditions absolutely undermine emotional well-being and mental health, and poor mental health undermines your health. So there's an intersection there that needs to be addressed. And what we do know is for this population, when people are employed, they do better. Next slide. So I'm going to do a quick care study. This is a de-identified case. There is no Mr. D, but we'll call him Mr. D for the purposes of this quick overview. He's a 30-year-old male diagnosed with IDD since the age of 2 and schizophrenia since the age of 17. Mr. D has periods when he's unable to sleep, followed by dysregulation and aggression. 85% of the people who end up in the emergency department for mental health issues who have IDD are referred due to aggression. And the police are often the ones who bring them to the emergency department, which was the case with Mr. D. So what usually happens, the intervention strategies include determining the level of acuity and to address their immediate needs, refer them to the providers that need to address those needs, and work with linkage partners. If the person is hospitalized, the START team will go and work with the inpatient unit and help as a liaison, a translator of how to treat Mr. D, how to understand how he's communicating, and how Mr. D can contribute to his own care, and conduct crisis evaluation, review historical patient records, very comprehensive look. We want to know when Mr. D did his best and what happened since then, determine any further assessments that are needed, and survey the individual and his family and his caregivers and himself about his service experiences. So the START team provides care, provides surveys of caregivers, but also surveys of people with lived experiences are being developed now with a current grant that we have. We really feel like people with developmental disabilities and intellectual disabilities should have greater opportunity to describe their own experiences and their own needs with regard to mental health services. We supply research and coaching, and throughout the process engage in our practices are humanistic in focus. We focus on positive psychology as well as other avenues, including expressive therapy and OT services. We strength spot, we have gratitude exercise, health practices, etc. So Mr. D was never readmitted to a psychiatric inpatient unit, although he did use crisis beds at times. One of the things that ended up happening was during the process of getting to know Mr. D, we learned that he had temporal lobe epilepsy and suffered from partial complex seizures. All his medications, his polypharmacy to treat his mental health, actually lowered his seizure threshold, and his aggressive episodes increased as a result of the mental health treatment that he had, and he ended up back in the hospital with more medications. So as we learned more about what was going on with him, we realized that his episodes were much more likely triggered by seizures and post-ictal activity than psychosis. Mr. D actually learned to recognize when he was having an aura. He actually would tell you your shoulders were shrinking. He noticed things in terms of his experience with seizure activity, and this helped guide his system of support. So his words, his experience, helped guide our learning. Next slide. So health plans should actively engage in data collection and outcomes to ensure best practices for individuals with IDD. Data, data, data. It's what you're looking for that matters and how you use the data. But if you collect demographic, clinical, and service outcomes for every person that receives care, you will learn how to improve care. Over time, identifying best practices based on beneficiaries experiencing positive outcomes is key. Not assuming that because you have IDD, you can't tell people what you're experiencing. Those people with intellectual and developmental disabilities do have something to say, and it's our job to be able to hear them and listen. Working in partnership toward improved research practices is key. We have developed with our colleagues across the country the National Research Consortium on Mental Health and Intellectual and Developmental Disabilities. You can find it on our website, and it aims to advance research on best practices and policy toward positive outcomes amongst people with IDD-MH, emotional well-being, and mental health, not just the treatment of illness. Consider funding research about well-being, the promotion of health, and including individuals with IDD-MH is needed. Next slide. So here are a couple of resources that you might find useful. We are now embarking on a study with Dartmouth Medical School utilizing the Integrated Mental Health Treatment Guidelines for Prescribers that you can find on the website link here. It's free, and we are training residents and interns in prescribing practices. And you cannot just focus on psychiatrists because 85% of medications are prescribed by people who are not psychiatrists. Evaluation of telehealth services is also going on in order to ensure that when people receive telehealth services, they can gain maximum benefit. Next slide. You have to attend to the 3 A's of service effectiveness. This is a key takeaway. Access to care. Care must be inclusive, timely, and community-based. It has to be appropriate. Outreach, training, and collaboration are key to improving appropriateness of services. And we all need to be accountable. We have to have outcome measures that are clearly defined, and review of data must be frequent and ongoing. There is evidence of great improvement when we work together to improve capacity. Strength-based approaches and integrated health, cross-systems collaboration are key, and a solutions-focused approach builds capacity through primary interventions, includes secondary interventions with expertise for specialized approaches, and a safety net for emergency interventions. Next slide. Thank you.
Thank you very much, Dr. Beasley. So we will move into the questions then, based on your presentation. Thank you so much. There was a lot of great information there, and we did get some great questions coming in. The first, there's 2 questions from the registration that we'd like to start with. One question that came in, how do you recommend striking that balance between meeting the needs of the patient and the requests of caregivers?
So the first thing you need to do in striking that balance is acknowledge that those are 2 different perspectives. I think in the past what we tried to do was have the caregivers represent the voice of the person or the patient. And the balance will come from actually listening to and attending to both and understanding that there's a context to which health can be promoted and a context in which health can be undermined. So that would be the first thing I would do, would be to find mechanisms to have separate conversations and engagement with the patient and with their caregiver.
So piggybacking off of that question, there was a follow-up. What are some of the lessons learned in working with caregivers if there's a need to have a more in-depth conversation on best managing the needs of the individual?
So one of the things that happened in an early study that I conducted several years ago was I tried to evaluate what drives the crises. Why do caregivers call for help? What are the issues with people with IDD-MH that result in emergency service use? And I tried to control for several variables, including aggression, diagnoses, polypharmacy, health conditions, etc. The most significant predictor of somebody having difficulty was whether or not the caregiver had support. So caregivers who, especially in families, primary caregivers who were sole source caregivers without additional support in the home were far more likely to use emergency services and far less likely to use planned services. So I think what we don't really pay enough attention to is the caregiving context, and really shoring that up will really help get better outcomes.
Great. If we can shift gears, one of the live questions that came in had to do with building linkages across clinical teams. Can you share how linkages can be built across teams and the mechanisms that can strengthen those linkages, for example, regular team meetings among the care teams, or are there other examples you can cite?
So one of the reasons why I started on this path toward linkages is when somebody has mental health needs in IDD, the clarity with regard to roles and responsibility, it just doesn't exist. So one of the biggest goals in developing linkages is for everybody to sort of come together and say what they have to offer to the person, what their system can provide, and what they need from their partners. And so the linkage agreements really start out with a discussion about roles and responsibilities. In order for that to happen, there needs to be a primary element, a primary resource. For example, what I believe Dr. Deutsch will be talking about, a care manager, for example, to help foster those linkages and bring people together and be a translator between systems, because the systems do not often speak the same language, and that's what undermines the ability to link.
Great. We do have time for perhaps one or maybe two more questions. One question that's come in, certainly I think people are interested in learning more about the START program. If someone is interested in learning more about the program, or perhaps investigating how to bring a model like the START program to their community, how do you suggest they begin to explore bringing a START model to where someone lives? So
you can look at the centerforstartservices.com. We have a website. Just type in Center for Start Services. It should pop up. We have lots of resources there. And if you have any questions after looking around, feel free to email me, and I will connect you to the right people to talk about it.
Fantastic. Thank you so much, Dr. Beasley. And as a reminder for everyone, we do appreciate all the questions being asked. We will do our best following the webinar to provide a supplemental material to answer some questions that perhaps we couldn't get to today. So please, if we did not get to your question, please refer back to the resources following the webinar. And with that, I'm happy to take us to our final presenter, Dr. Steve Deutsch, who will be presenting a managed care approach to improve the quality of care for persons with IDD. Dr. Deutsch.
Good afternoon, everyone. I'm Steve Deutsch. I'm the Chief Medical Officer of Partners Health Plan. And I'm going to be talking about managed care and its value in dealing with the health and social issues incurred by the IDD population. Can I have the next slide, please? Partners Health Plan, just to give you a little background, is a managed care plan that's exclusively dedicated to serving persons with IDD. It went live in April of 2016, and it's the only program nationally that exclusively serves dually eligible individuals with IDD. We have about 1,650 members. Next slide, please. Managed care really is the platform that's necessary, I think, for dealing with the IDD population. It provides the appropriate setting to gather data, key elements regarding health issues, utilization, and costs related to the IDD population. And it's this data that helps to identify suboptimal healthcare outcomes among the IDD population. And in identifying these outcomes, this data is used, and we used it to build new programs that we thought could, in fact, improve the outcomes for our members and improve the quality of care, and at the same time provide the baseline to, in fact, measure these outcomes. As we were putting these programs together, it became very apparent that no one discipline had all the skill sets to implement these programs, and that we needed an integrated clinical approach, a collaborative approach among multiple disciplines. So I'm going to be talking for the remainder of my talk about these 4 programs that we've put together. I'm going to give you some outcomes and some key takeaways. Can I have the next slide, please? In managing people, our members that are inpatients in hospital and skilled nursing facilities, our main tool is our clinical rounds. We do this every Thursday. It's based on a census which comes out on Monday or Tuesday, and we review all of our members that are in these facilities. It's a multidisciplinary team that participates in this process. It is really, really critically important. Next slide, please. We look at various things, and you can look at this slide and you'll see we look at the medical status, we look at management approaches dealing with various issues. But rather than talk about this, I want to give you some observations after doing this for a significant period of time that we deal with on a daily basis and that we're trying to improve constantly. First of all, with regard to admissions, somewhere between 20 and 30% of all hospital admissions for patients with the IDD population are inappropriate. There are multiple reasons for these inappropriate admissions, ranging from the inability of a member to communicate, a complex medical history without a lot of records to go with it, inappropriate admissions for post-ictal depression after seizures, and also things like a G-tube falls out. Why are we so intent on resolving this excessive admission process? Because we've experienced with these clinical rounds spirals of members who deteriorate both medically and physically after they've been hospitalized. And it's really amazing to see what happens to some of these people. And it starts a vicious cycle of rehospitalizations, et cetera. As far as concurrent care issues go, the hospital staffs, we've worked hard to educate them because there's often a lack of understanding or ability to meet the needs of the IDD population. And this can be related to time constraints in the hospital, communication, or quite frankly, some of the behavior issues from our members. Some of the behavioral issues that our members exhibit in the hospital are outbursts or misinterpreted as outbursts trying to communicate or outbursts related to fear. They also fail to eat, and then that raises the issue of G-tubes, or they fail to participate in physical therapy, and that raises the issue of deconditioning and an increased number of people that need to go on to a skilled nursing facility program. The staff oftentimes, because of functional disabilities, fails to mobilize our members as much as they do non-IDD people, and as a result, again, they get deconditioning and we see skin breakdown. As far as medical regimens go, you've heard my predecessor say that there are complicated medical regimens, and that's putting it mildly, often compounded by psychotropic drugs. And a lack of understanding of these drugs, even on the hospitalist staff in the hospital, and also a lack of information to reconcile drugs from outpatient to inpatient. We deal with lack of advanced directives, and a number of our people are over the age of 55. We deal with social issues related to identification of a guardian or bureaucratic processes if there is no guardian. We've had to deal with social issues related to caregiver capabilities, even to the point of wondering if the admission was related to deteriorating caregivers. Many of our people who are older have even older parents who, again, are becoming incapacitated. Also, in discharge planning, we have issues related to people going back to the group home, the residence that they were in. There's either a lack of staff or training for that staff because of a new condition that the member has incurred. There are physical barriers related to getting somebody back who was an independent ambulator and now needs a walker. And there's evacuation criteria on a time basis that's set up by the state. Also, we deal with rapidly procuring durable medical equipment. And then last but not least, safety issues related to the patient's previous environment. Is it safe for them to go back, or then do they need a different level of care? Next slide, please. The next program I want to talk about is our clinical pharmacy medication management program. This is a program that we developed. We started late in 2017 and have expanded it since. And it's a program that is done by the clinical pharmacists on our team. And they do what we call a comprehensive medication therapy review. And after this, I'm going to refer to it as a CMTR. It's based on current outpatient and or inpatient medications. It is based on a review on a weekly basis of the PDE files that we get from CMS, which shows fills, refills, in drugs, and also whether or not somebody's been taking their medication, whether they've been adhering. It's based on a review of a clinical medical record. And one of the things we did early on is we built a patient profile from claims data. Traditionally in managed care, claims data is used more for utilization numbers. It's used for financial issues. We were able to take that claims data and build a whole medical record for the patient, including diagnoses, hospitalizations, office visits, medication fills, numerous things, DME, what programs there have been, so that we have a great picture of that member, which the clinical pharmacist can look at and put together with the other pharmacokinetic issues that they deal with. We use this program for transitions of care from the hospital or from the nursing home. We use it sometimes. We ask for the medication regimen from the hospitals. We're doing rounds because the pharmacist suspects that the medications may have been the cause of the admission. We do it for polypharmacy, and we define polypharmacy as more than 8 medications. We do it for the management of chronic conditions, and if a staff or provider requests a CMTR. Now, once the CMTR is done, it's graded. We have a grading system based on the reasons we put down as high, medium, and low. All of the CMTRs, regardless of how they're graded, are in fact sent to the providers. However, when it's high or when it is medium, we expect a response from the provider. They may agree with the pharmacist. They may say, I'll follow up with the patient. They may say, I didn't prescribe this. But we have found lots of issues with people either overprescribing, being nice because they thought they were filling prescriptions, et cetera. Gratifyingly, about 85 to 87% of the providers send back their responses. So that is really very, very helpful. But these CMTRs finds all kinds of things. The most common one, about 22%, is medication interactions. About 22% is what we deem ineffective medication. About 17% is unnecessary medication. And it goes from there. The next one is needing additional medication. So it's not only taking it away, but sometimes it needs to be added or the doses need to be adjusted. And we have found multiple admissions related to medications, psychotropic drugs, for instance, causing hypothermia, misinterpreted as sepsis, syncope and dizziness, bleeding, arrhythmias. I can go on and on. Drug interactions which cause psychiatric admissions because of aggressiveness. So it's really a very worthwhile program. Next slide, please. The next program is a more traditional one that is in a lot of plans, and it's a care management program. But ours is pretty unique because each person has a 2-member team. The clinical team leader, which is a nurse or MSW, who also is the one that participates in clinical rounds, has under he or she 4 care managers at a bachelor's level. The team itself does an initial assessment of the patient when they first come in and creates a life plan, and then every 6 months reassesses that patient. At the same time, they do a dynamic risk stratification, and this determines how often they will do interventions to catch up with the patient, whether it's monthly, whether it's weekly. It depends on the situation. But the key in this model is, in fact, the collaboration between the care management team, which really deals, for instance, in clinical rounds, with discharge issues, social issues, and actually gathering data, even lab data, and collaborating with the healthcare members on the team. It really works well, and they really work as a team, and it's critically important. Next slide, please. Last but not least, I want to talk about telemedicine. Now, I want to give you some background in this because I think it's really an interesting process. We started telemedicine long before the pandemic, which has popularized it. We looked at our data in 2016 and 17, and we realized that 53% of our patients who went to the emergency room were admitted. We then reviewed Spark data from 2015, and that's a database from New York State Department of Health, in New York. And what we saw there was that if you were a non-IDD patient and hit the emergency room, your chances of getting admitted were somewhere between 10 and 16% compared to 40 to 45% for patients with IDD. So a huge difference. We decided we needed to do something about that, and we decided the best way was to do a pilot program with telemedicine. We put out criteria for a company we wanted to work with, and we came up with a company called StationMD. It's a company that specializes in this process. They are board-certified emergency room physicians who have also had additional training in caring for individuals with IDD. They had developed kiosks that go into residences so they can do with the equipment in those kiosks and training the DSP staff in the residences. They can do virtual physical exams. And for the community, we have an app. And for people who have multiple comorbidities, we can put in equipment so a virtual physical exam can also be done. In addition, the StationMD physicians have immediate access to the medical records, the patient profiles that I described for the clinical pharmacist. So when they're beginning to talk to a patient, they know that patient's history, they know their medications, they know their admissions, they know all kinds of information. So this isn't a cold call whatsoever. Next slide, please. The pilot program was so successful in 2018 in the sense that out of all of the phone calls, only 11% were sent to the emergency room. 89% were treated in place. It was so successful that in 2019, we offered the program to the entire membership. And what happens is this. If medically appropriate, the StationMD will treat somebody in place. And this includes prescribing medications, following up in 2 hours or the next morning, et cetera. If that person needs to go to the emergency room, as deemed so by the StationMD physician, they will call ahead of time, notify the emergency room, give them the history, tell them why they're sending them in. After the workup is done, they will talk with the emergency room physician, and they will, in fact, together decide if the patient needs to be admitted. Just a little point in time. What I was told is a lot of emergency room physicians will admit somebody with IDD because they don't know who's going to care for them on the outside if they let them go, even if they could. So it's been very successful, and we have we also built a financial model, and since 2020, the estimated ER and admission cost avoidance from the StationMD program is greater than $5.7 million. Next slide. So let me give you some key takeaways, and both of my colleagues who gave great talks previously have basically said the same thing. Number one, data is key to understanding and managing the healthcare and social needs of people with IDD on a population, but also on a member-centric basis. And I'll elaborate that in a minute. Managed care is the ideal platform to collect this data. How successful has this been integrating this whole process using a multidisciplinary team? For instance, since 2018, we've reduced hospital admissions by 42%, down from 413 per thousand down to 239 per thousand, and another number, 30-day readmissions have been reduced by 30%. Again, I want to emphasize that hospital admissions for people with IDD oftentimes are inappropriate and have devastating and lasting physical and behavioral effects. Medication management is a critical component in dealing with the IDD population. The pharmacists, when it comes to pharmacokinetics and drug interactions, really know best. Give you an example. Out of 500 medical regimens that we reviewed in 2021, 60% had significant findings that could affect the member's health. were accountable for admissions or we felt would potentially result in a hospital admission if not changed. And last but not least, telemedicine has been highly effective reactive. I'm going to emphasize reactive tool for outpatient management of the IDD population. As we gather data, we are now in the process of looking at proactive programs. We've analyzed data from emergency room visits and on key individuals. And what we found that we can deal with urinary tract infections, head injuries, diabetes and constipation on a proactive basis. In conjunction with Station MD, we've developed treatment regimens. We are training people in the residences of people that have these issues, and we have identified on a centric basis who these people are. And we have programs where, for instance, for urinary tract infection, they get a weekly dipstick. If it changes, the nitrates come up, Station MD is called, and they will intercede. This is a very proactive process now to prevent things escalating to a point where somebody needs to go to the emergency room or getting admitted. And we are using this with our DD providers to share savings. So there's a value-based component now going forward with this proactive process. So I want to thank you for your time. I think all of the speakers have reflected a common theme with IDD, but PHP represents a working model that continues to go on and I think emphasizes the value of managed care in dealing with and coordinating care for the IDD population. Thank you.
Thank you so much, Dr. Deutsch. We'll move right into questions. And one of the registration questions that came in, Dr. Deutsch, is when your care management team are serving members with IDD, very often those members may have other care managers or care coordinators that have been part of that individual's network. How do you ensure coordinated communication for members if they have other parties or managers that are involved in their service delivery?
Great question. First of all, when we get somebody in the program, we pretty much conscript them and we do most of the care coordination. But if they have people in other programs, the care managers, the clinical team leaders will reach out to them and they will coordinate with them so that we're not taking anything away, but we make sure there's coordination in the process.
Great. One question that also came through during the registration period, through your work and through the work of your teams engaging and working with the providers in the community, have you noticed any impact that your services have been able to provide that have perhaps addressed or aided community organizations in dealing with staff turnover or burnout? Do you have any recommendations for community providers on ways to address staff turnover and burnout at more long-term care facilities or community-based locations where some of your members may reside?
That's a difficult problem and a good question, and we really don't have a lot of control over things such as burnout in the residences or in the clinics that we work with, the article, what we call in New York, the Article 28s, the Article 16s, or the federally qualified healthcare centers. What's happening in New York at this point is one of the things that's come up is a new budget to more fairly pay the DSP population and hopefully attract more people into this profession by paying them better and training them better. But we don't have direct effect on that other than the fact that we help support them as we facilitate the care of our members, in this process.
Great, thank you for that. We got a question that came in on the Q&A, and it's very straightforward. How does PHP track participant satisfaction with your care coordination approach?
That's a great question, and I'm going to expand upon that. Number one, in order to do that, we do satisfaction surveys, okay? So on an annual basis, we do patient satisfaction surveys. a large percentage of them are filled out by the caregivers, but we do this. But I want to make a point that I didn't before. Because it's a managed care plan, because we adhere to HEDIS, we meet certain standards for preventative care, and that's critically important. And we've met and exceeded federal standards for things like colonoscopies, for breast imaging, for other preventative care. And because it's managed care, our people are not losing out on the preventative care that they should be getting. And by the way, somebody had mentioned the fact about imaging, and we went to battle and explained, and we got the fact that we would cover a lot of our people couldn't tolerate mammograms, so they get breast ultrasounds. With dental care, we have places where we can do desensitization and anesthesia, and we have a high percentage of people who get annual dental care. So I just wanted to bring that up as part of that question.
Great, thank you for that. We still have a couple of minutes left, and we wanted to give you the opportunity, Dr. Beasley, Dr. Deutsch, if there are other outcomes you'd like to highlight through the plan's work, any opportunities where the plan has really made an impact.
As I said, I think we've lowered emergency room visits, although there's been a little bit of a cost shift because a lot of admissions that people that would have been admitted in the emergency room would have been incorporated in the prospective payment system now sit as emergency room visits. But we've lowered emergency room visits. We have lowered readmissions. I believe that our admission rate now is in the realm of almost commercial insurance. And please understand that our members range both in the community and residences from 21 up until the 80s and 90s. So we have a significant older population that we deal with at the same time. So I think we have great outcome numbers. Again, I've tried to share numbers on our clinical pharmacy program, utilization, and again, our numbers, we get a withhold on quality of care issues such as dental visits, eye visits, and all of the above, either through HEDIS or through the state of New York through Medicaid, and we have exceeded those numbers that are given out to ordinary plans where the majority of people are non-IDD.
Great, and we have time for one last question. Dr. Deutsch, how can people, I think there are many people on the call that want to learn more about Station MD. How can they learn more information about Station MD and the benefits from that program?
Yeah, they can, Station MD has a website. They can go ahead and look that up. But I just want to warn you, it's not just getting the telemedicine program, it's integrating it. As I said, it's really key. We set up a lot of criteria before we chose somebody. Again, they have that medical record they look at. So it's not a blind call back to somebody that, that has to get history from a DSP and a member who might not be communicative. They have that medical history. That's one thing. We also, they're developing some behavioral health services for frequent users, which we've identified that go to the emergency room for attention seeking or other issues. But you can look them up on the website and realize that you need to coordinate with them. You just can't let them go by themselves and set criteria such as making sure they share their encounters in an encrypted basis with the PCP. I didn't get into a lot of detail, but that's all very important. But if anybody wants to reach out to me, I'll be happy to help them with that. But they do have a website. It should be under Station MD.
Thank you so much. Thank you so much, Dr. Deutsch, and all the presenters and all the participants today who asked great questions and our presenters who provided great answers. At this point, I will kick it over to Melanie Norris, who will take us through the final few slides. Melanie?
Thank you, John, and I echo your sentiments. Thank you to all our presenters. We are coming to the close of our webinar, so we've gotten through all the questions that we have time for today. If you have additional questions or comments, please email us at Rick, R-I-C, @lewin.com. As a reminder, this webinar was recorded, and there will be a video replay, and the slides will be available at resourcesforintegratedcare.com. Additionally, if you are applying for NSAWCE credits or CNE contact hours, just a friendly reminder that you must complete the post-test, which is linked in this slide, and we'll also be pushing out the link through the Q&A pod in order to receive credit with that 80% or higher passing rate. We want to thank you so much for joining us today. Please complete our brief evaluation of our webinar so that we can continue to deliver high-quality presentations to you all. Your feedback is important to us. The link is on the slide, as well as being pushed out via the Q&A pod. For more information on IDD, we have provided a list of resources on this slide. There was plenty of really great resources as well mentioned throughout the duration of the presentations today. We are developing 2 informative briefs on polypharmacy that was touched on today, as well as telehealth for the IDD population. So please be sure to check out our website for these resources. They will be coming out soon. And again, I want to extend our sincerest thanks and gratitude to our speakers from today. We appreciate you taking the time out of your busy schedules to share your expertise. And thank you to our audience for your participation and engagement. We hope all of you have a wonderful afternoon. Thank you.